Hello everyone. Today I'm going to talk about improving the hospital experience. Approximately 40 million people are hospitalized in the United States every year. Now that's a lot of people. Let's stop for a minute and think about a couple of words that we use all the time. The word patient. Now, are we implying that patients need to be patient? Is that what being a patient is all about? Look at the word hospital, how similar it is to the word hospitality. Is that what hospitals are all about? Hospital experience and improving patient satisfaction are being discussed in hospital boardrooms up and down the country. However, the terms have really become bumper stickers among a lot of hospital administrations, because we talk about them a lot and don't really get to the core of what drives patient experience and how we can do a better job. Because really, when we dissect it out, it's not rocket science. It really isn't. So in the last several years, I have worked up and down the East Coast in a variety of different hospitals, ranging from large tertiary care centers to more rural outposts. And I have noticed the same problems recur everywhere, regardless of where you're talking about. And really, these are 7 quite simple problems that I'm going to focus on, and hopefully we can talk about some solutions as well. So first and foremost, patients will complain that they simply do not have enough time with their doctors or even their nurses. This has to be taken seriously, but at the same time, I'm not suggesting that it's realistic that doctors and nurses can spend hours with every patient, but we certainly have to do a better job of making sure that we have enough time to communicate what we need to. Hospitals are by nature very rushed environments. When we ask patients, bedside manner complaints will be a frequent concern. They just do not think that we did a good enough job with that. Now, doctors and even nurses, we all learn about communication techniques in school, but during a rushed day, busy day, it's easy to forget some important things we should do. Simply sitting down with our patient, as opposed to towering over their bed, can make an enormous difference to how any interaction is perceived. We sit down face to face with the patient, maintain good eye contact. Actually, in any arena of life, not just in healthcare, but the same amount of time is perceived as longer if a doctor is sitting down as opposed to standing up. And again, that happens anywhere. When we're with our patients, we should be asking open-ended questions. Again, this is something we learn a lot, but don't do during a rushed and busy day. At the end of the interaction, summarize everything and give a patient and their family a chance to ask questions. We need to allow patients to speak and express what they're thinking. And remember, illness is a very emotional time, so often patients will have a lot of information for us, and we can certainly direct them in the right direction, but we have to give them a chance to offload all of their information and what they feel is important. And if we're talking about healthcare costs, as all of us are at the moment, when we actually sit down with patients, especially elderly patients, we often realize that they don't want certain tests done, or they may have even had the same test done within a short time period, maybe a few weeks or a few months before, so you don't need to repeat that echocardiogram or that CT scan. Number 2 on our problem list, which I call too many cooks in the kitchen syndrome. Again, this plays out in every hospital all across the country. What do I mean by this? Now, when a patient, especially in a complex medical case, comes in, they will frequently be seen by many different specialists within a short space of time. They could be cardiologists, they could be pulmonologists, kidney specialists, infectious disease specialists, And what happens is patients and families are getting loads of information, and often conflicting information. A classic example is the cardiologist who comes in and says, oh yes, your heart is the problem, and then the pulmonologist, the lung specialist, will come in and say, oh, your lungs are the problem, and patients and families will be kind of left in limbo and not knowing exactly what's wrong. So how do we solve this? Well, we really need to make clear who the captain of the ship is. Typically that will be the internal medicine doctor like myself, a hospital physician, or the internist if they still round on their patients in the hospital, but that will be the go-to doctor who should be coordinating everything and be able to communicate the right information to the families and the patients themselves in terms of what is happening. But they simply can't be getting all this information and differing opinions and sometimes diagnoses. It's very confusing for everyone involved. So number 3 on the list, food and sleep. Now, these are 2 very basic things which all of us need, especially when we are unwell, but we get them wrong when patients are hospitalized. They are 2 basic functions and we need them even more, as I said, when we're unwell. Myself as a doctor, when I enter a patient's room first thing in the morning, often their first complaint will be that they couldn't sleep, either due to a noisy neighbor or commotion going on outside. It's unrealistic to expect complete quiet in a hospital, but we can do a lot better. We can have quiet times, dedicated quiet times, and all staff need to be aware of that. We can also avoid other things such as taking vital signs, taking blood pressure at night in a completely stable patient might not be necessary. We don't need to wake them up for it. If any patient is having a lot of difficulty due to a noisy neighbor, it's our job to take that seriously. Can we switch rooms? Can we give them a better time and an experience when they're in the hospital and their bodies need to recover? Hospital food. Now, this has become the butt of all jokes in the hospital. And I often joke myself when patients complain to me about the food that we can't make hospital food too good, otherwise they'll have no incentive to get better. But all joking aside, there are frequently things we can do to help. We can involve the nutritionist, we can involve the dietary team to address complaints that patients may have, and sometimes if they want to bring in their own food, that should be allowed as well, as long as it's not going against the diet we need them to have, for instance in a cardiac condition. Medication reconciliation. This is an enormous problem. What do I mean by this? Now, medication reconciliation basically means that we list clearly what medications the patient was on before they come in, and then continue the medications that they still should be on. Obviously, some adjustments may be needed when they're in the hospital, but we need to know what patients are on at home. Why is this a problem? Well, because frequently in elderly patients who take a dozen or so medications, they won't remember the doses or the names of the medications, their family won't. And ironically, actually, healthcare IT can actually make this situation worse, because you will go to the computer and there'll be multiple different lists, all slightly different, and we won't know exact dosages of the patient's medications. Some techniques that can be utilized to improve on this situation, because let's be realistic, doctors and nurses often don't have enough time to dedicate to this issue, is we get somebody from the pharmacy, like a pharmacy technician, to actually go over all of the medications with the patient and make sure that we're continuing with the ones that they need to be on. I've seen that technique employed in the best hospitals. Ultimately, what we need is a no ifs, ands, or buts list. We need to be really clear on what patients were on before they came into the hospital. Wait times. Now, hospitals are places where you have to wait for tests. Of course they are. But often patients are left in limbo, not knowing what time, and this could be any time frame. We tell patients that they may be having a test between 9 and 5. We leave them NPO, which means not eating anything, and they'll be there, and sometimes the test will even be cancelled. But we can do a lot better in at least giving them a better time frame of when they're going to have tests And what I find is that patients and families are fine with waiting even a day or two, as long as we're completely honest about that from the beginning and don't leave them in limbo. Healthcare information technology. I will spare you my 5-hour lecture on this issue, but this is one of the most critical issues facing frontline medicine at the moment. Why is this? Well, it's a challenge because over the last decade, hospitals and clinics have rapidly rolled out information technology systems in response to federal stimulus money, which was allocated to hospitals that did so. And obviously with that incentive, hospitals rushed everything out to comply, but unfortunately the IT systems themselves were not ready for prime time. So as a result, doctors and nurses are left with inefficient, suboptimal, and very clunky systems that take far too long to navigate, and statistics now suggest that new doctors are spending a minimal amount of time in direct patient care, as little as 10% of their time. That's a disaster for the practice of frontline medicine. Doctors and nurses should be with their patients as much as possible and not spending the majority of their day clicking boxes on a computer. Funnily enough too, patients will often complain if their physician doesn't even look them in the eye anymore and is instead just staring at a screen and paying them little attention. So this is an issue for both doctors, nurses, and patients as well, and we need to do a lot better and swing the pendulum back to direct patient care with more seamless IT solutions, and I use the term seen and not heard. So computer systems which are very quick, easy to use, and help take us back to where we should be with our patients. Other solutions to this which have been proposed are the use of scribes. So by that we mean someone who is with the doctor typically and does all the documentation work for them, so that they have more time to see patients and be more productive as well. Lastly, when patients are discharged, frequently the process is too rushed and haphazard. And as a result, again, patients and families are confused about what the diagnosis was and what needs to happen when they leave the hospital. This is an issue now, especially because we're in an era where readmissions to hospital are a huge issue and hospitals are being penalized for them. So we need to ensure that when patients are discharged, especially older patients, that everything is crystal clear. We need to give extremely clear discharge instructions that note the diagnosis, any abnormal tests that were given, timely follow-up with physicians, especially the primary care doctor, should be arranged, what tests need to be done in terms of blood tests or imaging studies. Importantly too, medication changes. When patients are in hospital, their medications are usually changed upon discharge, especially if they were very unwell, and that needs to be kept track of, and the patient needs to know about this as well. Finally, recourse. If patients go home and things don't work out well, if they start to experience more symptoms, what should they do? Who should they contact? Is there any way that they can avoid coming back into the hospital? So, in conclusion, they may sound like 7 very simple problems, but address these issues and we will make a huge difference to every hospitalized patient, not just in this country, but everywhere. As we often do in healthcare, we get stuck in things and propose overly complicated and expensive solutions to problems which actually the solutions lie closer to home and are much more simple. And let's not forget that the core of good medicine is about compassion, empathy, and real human interactions. Strip everything bare and we are left with the doctor or nurse and the patient, and nothing beats practicing good and thorough medicine. We have indeed come very far. Let's not forget that for most of human history, life expectancy was in the 20s to 30s. Even at the turn of the last century in America, life expectancy was only in the mid-40s. Smallpox, we completely take for granted now that it's eradicated, but it's estimated that smallpox caused 500 million deaths throughout human history. To put that number into some perspective, That is more people than have died in every single war that has ever been fought since man first walked out of the cave. There was no anesthesia for surgeries up until the end of the 19th century. Look at any picture of hospitals from the early part of the 20th century and you'll see rows of patients lined up with conditions such as TB, and now the mantra is all about empty hospitals and keeping people at home, healthy, doing what they should be. We have made enormous advancements, and it's important we don't forget that, because there is more progress to come and the best days of healthcare and medicine lie ahead of us. Thank you very much, ladies and gentlemen.